Thank you from all of us to join us for the Patrick Palissy course today. We are happy to be with you, and Happy New Year again. I let the introduction do by Sue Hodendel, who is a global head sales and marketing of Thousand Implants, and enjoy the course, and see you after. Don't hesitate if you have any question to send your question in the module Q&A to have a reply from the collaborator of Patrick Palissy. Thank you, Sue.
Thank you very much. Good morning to our international audience and colleagues in France. Welcome, and thank you for taking the time to join us on this webinar. These unprecedented and challenging times, we all need encouragement, advice and guidance to cope and adapt to the changes brought on by the pandemic, while still treating patients efficiently, cost-effectively and within a reasonable time. In spite of the challenges of 2020, Southern used the opportunity brought on by the COVID-19 crisis to move things forward. We made substantial improvements and progress in our drive to comply with the new European MDR regulation. We also focused on new product developments that will enable you to treat your patients more efficiently. A special thank you to you, Dr. Palissy, and the BOC team in Marseille for your collaboration with our team in France to put together today's program. Our journey with Dr. Palissy started in 2015, and together with Emmanuel and his team, has grown from strength to strength. Dr. Palissy, we trust that using our special site-specific implants has had a positive impact on the treatment of patients in your clinic. We look forward to the lecture, your lecture, which will address the guidance we need on dental implant treatment in a pandemic context. I'm also looking forward to further collaboration with you. Thank you.
Okay. Good morning, Sue. It's a pleasure to see you again. And although it's a difficult situation, we have to adapt. And this is what we're doing now. And welcome to all my friends from all over the world. And it's a pleasure not to see you, but to feel you, which is what we can do today. We're going to start with the image. Okay. 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 We are going to speak this morning about the new situation and how we have to adapt in our practice to this new situation. And this is really extremely interesting to see that the world has changed within a year. We would never think last year in the same time that we would be in such a really incredible situation. I remember last year I was in beginning of February, just a year ago, in Maldives, diving, scuba diving, and we were there, and I saw some Chinese women were there, was in a lockdown because they couldn't go back to China. And they were in this island, 3 of them, stupid, staying there. And we say, what's going on? And we wouldn't rethink 1 minute that we would get the same situation within 2 more weeks. But now we have to think about what's going on in the world. And this we know because we are all looking to the news and everything to see what's going on. And this is a panic. But in our practice, we have to adapt. And it's really amazing to see that today, we see on the Facebook or whatever, that some doctors are showing exactly the same cases that they used to do before. It means these people didn't understand the situation change, and they show extremely sophisticated surgery with 3, 4, 5 surgeries to obtain the maximum optimal result, and patient coming back to the office and with a risk of complications. But this is another time. This finish. And we're going to see today how we can adapt and even treat extremely difficult cases with the best clinical. Okay. So today we have to work with this kind of protections. We need to be extremely safe. And patients, all of us know that our patients are frightened. And I think that I just was discussing with my son, who said COVID is a disease from fear, because people are so frightened now. And by being frightened, they're getting crazy. And the thing, they come to our office, but they need to feel safe. And to tell you the truth today, the best place I feel the safest in the world is my clinic, because we are so cautious, so careful, that I think that here the disease is out. And I think that we need to let the patient understand that this is our reality. They can come to the office, they feel safe, and all of you know that patients are looking. If your mask is going down a little bit like this, they look at you and they say, you see, so you have to be extremely careful. And I see some of my friends, the office is going down like this because they don't care. And patients are frightened. But if you show what you do, if you adapt to your situation, then patient will come. And I say there is no change in my clinic at all. I see less patients, but as I travel less, in fact, I don't travel anymore, I have more time to take care of my patients. I'm relaxed. I see one patient after the other one. Girls take the time they need, and patient feels safe, and everything is fine. And this is what I want to show you. You see, we need to get on top of the sterilization of the surface. We need to get the sterilization of the air. We need to recycle the air so that it's being nice and clean. We need to open the windows as well. And we have all the tools and the toys, we should say, to be in the best clinical situation. And we show this to the patient. They need to understand how much it costs for us, and how much time we spend, and what is the result, that they are in the best clinical situation. The other thing is, we need to use all the tools. Before we could extract a tooth like this, but now we want to be safe. So, for example, physiosurgery will allow me to extract the teeth in a basic clinical way to prevent destroying the labial plate of bone, you see, and preserve the ridge and be in a good situation, optimal situation to be in immediate loading. And speaking on immediate loading, we reduce the amount of appointments, and using the hostel as well will help us to stabilize and know where we are in this situation. And if we can save one or two cases, this is the best. Even when this is Theo, my partner, working like this, we need to work in the best way. And patients now feel safe when they see this kind of equipment. They know that we are not playing games, and now they see what we do, they understand the cost. Before, patients were discussing about how much it costs and blah, blah, blah. Now they come, they can pay, they do it. They even don't go anywhere. So I lost all these stupid patients who went from office to the other one to just compare the price. I lost them completely. Now they come, they do, or they don't. Finish. I saved half a day a week by these stupid kind of consultations. But it's not because that you are changing a little bit your practice, that you need to forget what you used to do. And of course, the technology, the CAT scan, the evolution, the guided surgery, or whatever you want, has to be a part of the treatment. And I'm going to tell you how we do and what we do. 15 years ago, Per-Ingvar Brandmark, who has always been ahead of everyone else, told us in the Brandmark Center, when possible, one should avoid unnecessary advanced and complicated major grafting procedures. He was right. And you know, for those who have listened to me or those who came down to my center in Marseille, that my philosophy is simplicity. Reduce this kind of major grafting. And because more grafts, more complications. And now, today, it's amazing to see that some doctors don't know that. They built little houses with pieces of bone, screws, tens, whatever like this. And the more complicated, the more risk for opening the wound, opening the graft, risk for complication, more visit to the office, more risk for contamination. So they want to come as minimum as they can. This you should understand. And today's philosophy matches totally what used to say P.I. Brennemark 15 years ago. Because implant treatment today, I used to think this before, but even more today, this kind of treatment should be less complicated, less invasive, because less invasive, less pains, less complication, less visit to the office because the patient swallow and they have pain, or blues, or black, and they are frightened because you can see something oozing from the graft or things like this. Should be less time consuming. The same. If you simplify the treatment, you don't spend too much time, less risk for complications, and better results. We should reduce the surgical sequences. We used to work in 2 stages. Why don't we work in 1 stage? Why not going more towards immediate loading, where the patient comes and he quits the office with teeth? We're going to discuss more about that. If we use biomaterial, we don't have to have many surgical sites. We have just 1 site and less morbidity. So they won't come again to your office to tell you, I have pain here, look, I'm blue, I don't feel my teeth because you took bone from here, there, or from the ramus because they don't feel anything less. And of course, simple treatment, less risk for contamination. And this is the key. This is what will bring you more patients, because they feel that they feel safe, they will pay, and the fear is that, and they don't want to be contaminated. This is extremely important, because some doctor some patient told me 2 days ago, he needed to go to the hospital to have, because he has a little not heart alert, and he went to see the cardiologist to say, you know what, you're going to stay 5 days in hospital because we just want to test if you're fine or not. And the guy told me, you know what, I'm not going there. I don't want to come there and go in the other side because I stayed a week in hospital and be contaminated. If I have a problem, let's see what happens. So once again, simplicity is a key for success. But if we're simple, treatment has to be more predictable, more reliable. We need to reduce the post-operative reactions, so they won't call. And we need to call them after surgery to know that if you call them the day after surgery and the 2-3 days after to see if everything is fine, they won't come to see you because they know you're there. And if they don't come, less patient, more relaxed for you, and everything will be on the safe side. If you do surgery, they will come, they come in emergency, they will fill your office with emergencies, more patients. You don't want that. And of course, we need to have a high success rate. It's why the use of Hostel or any kind of thing we're going to discuss is extremely important. And we go, if possible, we go to a cheaper treatment, because surgery will be simple and it will be cheaper. But again, cheaper is not the thing today. It's not the thing today, because the patient will pay. I have really seen in my practice, I'm sure you as well have seen that, because those patients come and they are ready to pay now. A year ago, same patient wouldn't do the treatment. 5 minutes ago, just now, I got a patient who said, you know what, I know it's expensive or this, but I've seen other doctors and I don't feel as safe as you in your office. Can I do the treatment and pay 3 times? I thought, of course, yes. But last year, she would have been in another center. Now I got this patient. She took the appointment just now, 5 minutes before. We were preparing, I was discussing with her. So this is what's happening. So the price is not today the most important thing. People will pay for that. And they will pay for excellence. They will pay for safety. Thing is, seems very complicated, a lot of questions to answer. How can we achieve these objectives? I'm going to show you through this morning how I did it and how I'm doing that every day. I'm going to show you my daily practice, not fancy surgeries and you're going to see that we can have simple treatment, but more difficult cases. And even in this situation, we can treat extreme cases. Look at this case. Patient comes, she lost tissue on the palatal side. She has a deep pocket on the palatal side. We need to extract those teeth, those 4 incisors, but she don't want to stay with the removable. She said, okay, she was frightened because there was this extraction to be performed for these 4 incisors. But they say, okay, if I can have a simple treatment, I would like to have that. I said, okay. I look at the X-ray, analyze the case, see what should be done, discuss carefully with the patient, and then after checking all the figures, taking the pictures, looking to the CAT scan, evaluating the length of the implants, we decided to place 2 implants for 4 teeth. We then use Hostel, the piezo surgery. I'm not selling anything. I have to tell you, I'm free, independent, pay my implants, pay my instruments, and I can say whatever I want. So who know me knows that this is a real truth. So I just show you what I do, and you do whatever you want. Very important. But I extract those teeth, okay? And now I see that I clean everything, prepare, and this is extremely important if you want to avoid breaking the labial plate of bone, to carefully extract these teeth. So your use of piezo surgery will help you to go around the teeth, disinsert the teeth, extract them, and preserve the ridge. And one of the risks for immediate loading is that you can destroy the labial plate of bone. And if this happens, bye-bye immediate loading, bye-bye fixed bridge, and maybe bye-bye patient, because if you tell them you're going to leave my office with fixed restoration and they leave with a denture, they are not really happy. Okay? Then time comes to place the implant. Place the implant into the position, and we need, when we place the implant, to use the ISQ scale more and more. Before, I have been using the Hostel for decades. It was very complicated. In the beginning, you have to take wires and adapt to the implant. And then we have easier machines. Now we have some machines extremely simple. The tools are so simple that we can use them. Takes a second to use, and then we can see and evaluate where are we in the case. Can we load it or not? Or is it a good clinical example for us or not? And then you have a value to tell your patient, your referring dentist, that this is the case or not for immediate loading. And if you tell the patient, look, the value is, let's say, 55 or 60, we take a big risk by doing immediate loading. I've never seen a patient say, yes, I want to take the risk. If you don't tell them this to the patient, they don't understand, you see? And if there is a failure, they are not involved in the treatment, okay? So this scale is critical for any practitioners who is placing implants to reduce the time, avoid premature loading, and establish a more predictable outcome with implant therapy. And when you have a high-risk patient, you can evaluate how is the value and understand if you want or not to take the risk. If you cannot go to immediate loading, you can evaluate the healing period. And if you wait, you can wait 2-3 months, check where you are, and know that you can or not load the implant. And if the value is too low, you don't need to construct the bridge because you know you're going to fail. So this is extremely important for the temporary restoration as well as the definitive restoration. Then with ISQ scale, we can reduce the treatment time, avoid the premature loading, provide predictable outcomes, and determine loading protocols. Immediate loading, early or delayed loading. We are going to discuss about the value. We should be over 65, but you have to adapt. We are going to discuss during this morning to adapt, and this is your personal idea. Will push you according to the case where you are into immediate loading or not. And this is not a fixed number. This is an adaptation of this clinical situation. Look, we place the implant, we use the device, the hostel, and now you put the smart peg onto the implant and evaluate. You immediately see that there is a green light here. Green light shows that you are over 70. Over 70, you have the belt and the suspenders. You are really in the safe situation. Safety belt. 75, 71, you know for this first implant, everything is fine. So let's check for the other implant. And this is the same. One was 75, the other one was 75, 71. So we can go to immediate loading with 2 long implants with no risk. And then it's a good idea. And if you think about the scale, the question is, what will you do? You see, if you are less than 60, this is too low. You cannot go for immediate loading. You can expect that from 60, it will go to 70. If you are 65, if you have 1 single implant, don't like it too much. If you have several implants and you connect them, maybe this can be a good situation. If you are with 2 implants, 40s, over 70, you are in a good range. So you can go to immediate loading. Then you can tell your patient where you are, and you are not going to face failures, problem with the patient coming within 2-3 weeks with a mobile bridge, and this is not unscrewed, it's just that you lost integrity. And if you lost integrity, it's more sessions, more time, more risk from complication, and unhappy patients. So this is, my friends, a good tool. And the thing is, we're going now to take care of the reach. We used to do 15 years, 20 years ago, to use autogenous bone graft. But today, I've not done an autogenous bone graft for over 15 years. And I've done a lot of graft. And I didn't stop working. I even work more and more. So I'm using the biomaterial. I've been using the biomaterial from osteobiol for 17 years now. And I'm going in this case to use GTO, and Dr. Laplan, Theo will discuss with you about that. But you see what I do? I place the implants, put the smart peg, and I compact the biomaterial into the alveolar here. And this will become hard and will have enough bone between the implant and the ridge to be sure that this ridge will maintain. We have placed, you see, the healing abutment, and you can see the bone, which is compacted around the implant. And we're going to show you how we compact the bone. But now is a ridge. If you don't do anything, you will have long teeth. So it's a time to use this GTO, which is this new biomaterial we have been using now for 4 years. But from the evolution from MP3, so we have over 15 years background with the use of this biomaterial. But look, this biomaterial stick and can be modified, you see, and pre-shaped in order to augment the ridge. So we can pre-shape the material and place it over the ridge, you see, like that, and it will stay and it will become hard. We carefully reshape this, and we know now that we don't need a connective tissue graft, because this material, with hard tissue, we are going to play with soft tissue. We have a support, a hard tissue support for soft tissue. And soft tissue, for some reason, loves to have a hard tissue support, because this is what they get in nature. In nature, they got the bone. If they have a powder, they don't like really so much. If you have something which matches the density and the texture of the bone, soft tissue will heal perfectly well. And if you look at that, we started here for this case, you see, and we end up there for this immediate loading case. And we treated the upper jaw as well. This is our temporary crown, but look at the beauty of the restoration now. Look at the beauty of the soft tissue. This is 2 weeks later. We can see the shape of the sutures. 2 to 3 weeks. Look at that. We have the shape with a nice temporary restoration. Patient is extremely happy to get that. And now we are in a good situation, a good way to wait 4 months and go to the final restoration. So I tell you again, implant treatment should be simple. Why is immediate loading simple? Why is it simplicity? I have, through the years, I started placing implants 35 years ago. And through the years, I've met so many friends and excellent practitioners. Some of them, you start to discuss with them and you feel the chemistry. And some of them you trust, others you don't trust. And this is why the contact, the real feeling is important. When you look on the literature, you look on a lecture of someone, you're not sure how is the guy. Among the really good guy I've met is my dear friend from Chile, Robin Rosenberg. Robin Rosenberg is an incredible guy who has an office in Chile, Santiago de Chile, and I've been giving a lot of lectures for him in this place. And you have people you trust in life, you see, and I trust him and he trusts me. So we have had incredible exchange, and he knows that when I say something is right, and I know that he says something is right. And this guy is incredible. He has been placing so many implants. No one in the world is placing as many implants as he does. So when he tells me something, I listen to him. This is 2 years ago, I went to give a lecture in Chile, Santiago. Then we went to his house in center of Chile. And this is in a prehistoric forest where we used to walk together. And I was discussing, when we were in his house, you see, we're discussing about our experience. And I gave him a lot of soft tissue tricks and hard tissue tricks, and the same to him. And among the discussion we got was a discussion on immediate loading. And he told me, you know, Patrick, I'm doing more and more. And I made a study. I am going to show you what I did. This guy don't need any, he has shown everyone what he knows. In South America, he's really considered as a king, the purpose, dental implantology. And look at the figures, the number of implants he has placed. He made a study on his patient. His own patient is in own private clinic, Brand Marcos Integration, Santiago de Chile. And he started to discuss, to think about, do we need to go to immediate loading or delayed loading? And he analyzed his cases. He started to study in 2001, okay? And he made a personal study from 2001 to 2017. This is in 16 years. And you can see in blue the delayed loading, and in red the immediate loading. And you can see that he started with a lot of delayed loading and just 17, nothing in 2001. And you see the curve change. The red goes up and the ground goes down, but stays stable. But the thing which is incredible, look at the numbers of implants per year. Immediate loading, look, say 16 was 5,612 implants. Delay loading, 2,620 implants. That means that you are over 8,000 implants per year. So when I see these kind of numbers, when I see some people who discuss about in a university or whatever, about immediate loading and thing on 100 implants, 200 implants, I say, look, there's a big study or big university. This is what I do in a month, in 2 weeks. And this is a study on 5 years. And this study is on 16 years with, look at that, delay loading 46,512 implants. 46,000 implants, my friend. And he looked on those years, okay, 16 years, you can see the success rate and failures. 1,800 implants failed. So it's a lot, but it's just 3.9 failure rate, which is nothing, which is extremely good for these years, all patients combined. So it's meant to seem to be extremely interesting. But it's also interesting to look what happened on immediate loading. Look carefully, 3.9 failure rate on 46,000 implants. 60,000 implants and 619 implants, 1,900 failure. So failure rate, 3.1%. What does it mean? He had a higher success rate in immediate loading on 100,000 implants in immediate loading than delayed loading. And why he has a bigger success rate is because when it goes to delayed loading, these are more difficult cases with less good bone, maybe a type D4, which definitely by base are more difficult cases with a higher failure rate. So the question is, do we have more failures in immediate loading? The answer is no, definitely not. So if someone can argue with that, no problem with me. But this is why I listen to the guy. So, my friends, immediate loading is, if carefully planned, is a good connection between the brain and the hand, which is a key for success, can be valuable. Because implant treatment is a whole concept. It's not just place the implant when you have no bone, no brain, 2 left hands, and then it will fail. So you need to play with hard tissue, with soft tissue, with a prosthetic restoration, considering the aesthetics, but on top of that is a precision in implant positioning. Precision is a key for success. Simplicity and precision. Because you have to understand, to obtain this kind of result, that there is a base, there is a pyramid on the treatment. On the base are simple, easy implant treatment. On top of them are aesthetic implant treatment. For aesthetic implant treatment comes immediate loading, of course. But on this pyramid, all patients are not candidates to be on the top, and not every single dentist can lead and bring the patient to the top of the pyramid. A lot of patients to the base of the treatment, not so many patients to be on the top. A lot of dentists to treat the base of the treatment, not so many dentists to be on the top. It means that when you treat a patient, you should evaluate what is your level. Is your level here or there, or where is your patient, here or there? If this match, you know that you can treat the patient. So immediate loading is related as well with this treatment. But to obtain this pyramid, you need to build the hard tissue, the soft tissue, to be able to get a precise implant position. Among these factors is the hard tissue. I have been through years, I've been doing so many hard tissue reconstruction. I've used all the possible technique. We started by the sinus elevation together with my dear friend Peter Moy from Los Angeles, who helped me to do my first sinus elevation, where he came back to Marseille, and in 1988, I don't want to tell numbers like this because I feel so old now, but he came to Marseille and he showed me how to take bone from the hip, grind the bone, put the bone there. But then we stopped to do that because it was really a difficult surgery, tough surgery for the patient, morbidity. And then we started to mix autogenous bone graft with biomaterial. Today, a lot of practitioners still go to autogenous bone graft, which is a good thing. There's nothing against that. It used to be the gold standard before for everyone. Now it's not the gold standard for me anymore, because I got so beautiful results with biomaterial that I have stopped, I told you before, doing any autogenous bone graft. I am a little bit provocative. I don't want to tell if you do autogenous bone graft, it's no good. This is an excellent treatment. I have had wonderful results, but today we have to reduce the time, morbidity, expense, and risk for complications. If we can take some biomaterial from a syringe, have good result with that, predictable result, why should we go to more sophisticated and complicated restoration? So now, my dear friend Theo Laplan, my partner, is going to discuss with you a little bit about hard tissue and the new material we are using today. Theo, for you.
Great. Hi, everyone. So, it's okay. Let's speak about GTO and our some biomaterial that we use every day at the office for its wonderful properties. When we perform bone reconstructions, we need stability, and GTO gives us this property with ease. Using GTO is a great way to obtain very predictable clinical results, and we believe this helps to decrease the number of interventions. Less interventions, less appointments. In a pandemic situation, it's a good fact. So GTO is a xenograft biomaterial. Generally, we use porcine bone, but you can find also bovine or equine origin. GTO is composed of prehydrated, collagenated corticocancellous bone granules. Granules are prehydrated with TSV gel. TSV gel is a mix of type 1 collagen and type 3. More of that, you can find inside GTO some polyunsaturated fatty acids and a synthetic copolymer. As you can see on this picture, GTO is like a temporary filling material. You can shape it as you want and optimize the bone reconstruction, your bone graft, and more of that. When you place the GTO, it becomes harder at the oral temperature. So it's very easy to shape the bone defects reconstructions. So let's check together an example of a clinical case using GTO. So here on radiographic examination, we can see a major bone loss between the tooth 26 and 27 with apical lesions that you can't see very well here. There is more of that concavity, buccal concavity in the premolar area. On clinical examination, we can see a significant recession on the first molar with a lack of attached gingiva. So we decided to extract carefully both molars, 26 and 27, and we carefully extract them so we preserve the surrounding bone, and we raise the flap. So we extract carefully with piezo. We will carefully, again, clean and decontaminate sockets, so you're sure it's clean. We put some GTO, we fill alveolars, and we take time to compact it. It's very important. You have to compact this biomaterial. So we placed over GTO a cube of collagen, and some suture were performed with glycolon. Glycolon is a monofilament suture absorbable. So you can see 4 months later. So 4 months later, we raise a new flap, and you can see the bone is extremely dense, well vascularized, and ready for the implants. So let's check together a video about the clinical case. So you will see we raise the flap again, and you will see the quality of the bone. So flap raised, look how dense is the bone and how well vascularized it. So we start the drilling with irrigation. Here's the drilling with positioning indicators. Second implant, parallel. Positioning indicator again. We always perform implant placement like that. It's very useful. So here you can see denser drills. So denser drills, we use them to make some osteointensification. So we can optimize primary stability. See the denser drills. So you see, you need many irrigation because it becomes hot with these denser drills. So here, placement of a plant. Not the parallelisms of the implant. And of course, axes are compatible with screw-retained prosthesis. We always work with screw-retained prosthesis. So we place four implants, and here you can see the use of Hostel. Hostel is, like Dr. Palassi said, you can evaluate the primary stability. We have height value, so it's posterior maxilla, and it's like mandibular. We place again more GTO, so we get perfect result. some APRF. So we will get better bone, better hard tissue and soft tissue. So we'll get perfect aesthetic result. Sutures again. No tension, very important. And here's the result. Here you can check the positionment. So the aim of this case is to show you the major advantage represented by the use of the GTO in your daily practice. If you use it, you will have more predictable results, less intervention, and less intervention, less appointment. So we think and we believe it's a very good tool that you have to add in your practice. So I will let again the Dr. Palassi speak and have a good continuation. If you have any question, don't hesitate to type it inside the chat and I will answer, no problem. So enjoy.
Okay, let's continue. Just to show you some cases, very simple case, to show you how we use this biomaterial and how can we change a difficult case in an easy case. This premolar has been extracted 3 months ago. Look on the left-hand side, look at the X-ray. Look at the bone we lost, and look on the right-hand side, the major defect we got. We just extracted the tooth carefully with the piezo, preserve the ridge, and we used the MP3 and we compacted the biomaterial. 3.5 months later, look at that. The bone is here, the ridge is there, and look at the density of the bone. We are over 70 now. We can go to immediate loading. So it means that we could never have gone through immediate loading previously because you have no bone. But after 3.5 months, we have the bone. It's bleeding, it's here, and we can just place the bone, place the implant, place the abutment, do the papilla regeneration technique. When we come back to the real life, I will give you more lectures on soft tissue, and preserve the mesial papilla, matrix suture, go above the papilla like this, onto the palatal side, carefully, suture above, there, simple distal. And the thing is that we have created the central papilla, okay, the mesial papilla. The thing is, if we stop here, you see that we have created nice papilla, but we didn't do the same thing for the distal one. And you may ask me, what can you do there? First of all, we know from the literature that Mother Nature will be on our side and we will gain 2 millimeters every time. So if we start with a nice papilla mesially, we will gain 2 millimeters, everything will be optimal, and distally we will gain 2 millimeters. The distal papilla will be shorter, but be there because of the basics. The other thing is that if you need to promote a papilla, you always need to promote the mesial papilla, because when the patient smiles, you always show the mesial papilla. So it's just simplicity. If you needed to have a distal papilla as well, we could have done at the time of implant placement or before or after a connective tissue graft in the distal to get an excess of tissue in the distal ridge. So then we could have ended with a nice double papilla. But now we continue, and you will see the result after 1 week. We can, in this time, the patient stayed for, she was coming from far away. She stayed for 4 months without any teeth. She was not in a hurry. She said, okay, do surgery, I have time, I go back home, and within 2 weeks, you can do the crown. I'm not, I could have done the crown the same day. But what do? We wait And when she comes for the impressions, this is what we would get after 8 days. 8 days, 10 days. Look at that. Mesial papilla is there. Tissue is nice. We can then take the impressions. And within 2 simple surgeries, we have treated this case. And what is extremely interesting is that the bone quality, starting from nothing, was so nice, so dense, that we were to 72. It means that we, starting from almost nothing, placing the MP3, we got the initial stability of the lower jaw bone. And you could see the bone was here with no granules, bleeding, healthy, and this is the implant. Now we can go to the temporary restoration, wait a little bit, and go to the final restoration you can do here. You see? Today we see we have done the papilla. We got a little bit of a concavity here, you see? You know what I would do today? Add GTO on the facial of this case, and I will match totally the same thing. But just to look at that. If you can do this for cases like this, simple cases, we can go to immediate loading to full arch. And I've been using now for several years these deep conical southern implants, and thanks to southern implants and Graham that they listen to my advices to get a more aggressive implant to be able to get a better initial stability to use this in all my cases for most of my cases in immediate loading. This implant is really fabulous. We are going to see the cases we can do. It's a mixture of aggressivity and smoothness to the neck. So we can use in several different situations, such as sinus elevation or lower jaws, being extremely safe with no problem. And of course, the results we got are incredibly good. But you have to understand as well that I've been discussing for years, over 15 years now, that I love using narrow implants. I've started using 3.3 Brennemark implants, and then 3.5 active or 3.5 deep conical. This is my main implant, because the question I wondered 15 years ago, do we need more bone and less titanium, or less bone and more titanium? 20 years ago, when the company developed 5mm implants, everyone jumped into that. And I realized that having more implants, more titanium and less bone was not the best, because my success rate after a few years was not the same. And then I thought, why don't we do the reverse? Because we need to promote biology. And the implant is healthy and solid. And especially with now with this treatment the company got with this deep conical, we have never got any fracture. Even if you use a 3mm, this can be done. So I'm not frightened at all to use narrow implants. I promote the bone. So if the ridge is a little narrow, use narrow implants. Even for full arch, you will see that. And this has been a major change in my practice, major, because I'm using today 70% or 60 to 70% of 3.5mm implants. I'm not just doing incisors, or lower or maxillary incisors. I'm doing everything. Okay, so between 3.5 to 4mm, and the 3mm is used really when you cannot do anything else. So lateral incisors, lower jaw, and things like this. But base of the treatment is 3.5mm implant. Look at that. If you compare the two implants, you compare the quantity of bone you got in both sides, and you can see with the narrow implant, we got more bone, more blood supply. And what does it mean? Better success rate. I've done personally a study on 3,000 implants, and my success rate was 98%. Extremely good on 10 years. So no worries. And I broke one implant when I was using Brandmark implant, and it was an extremely heavy fracture on a full arch, one case. So don't be frightened by breaking those implants. So let's see a case now on immediate loading, upper jaw. This patient knocked to our door. She has a removable denture, you can see. She's extremely unhappy with this removable denture, and she would love to have a fixed restoration. And of course, we could start with posterior region, place the implants, wait, stay with the removable, with the pressure we can give with a removable denture, especially in metal, when you do a sinus elevation, because you see that we need a sinus elevation. And then you can extract and place the teeth in front, wait, and this could be a treatment for 1 year. And today, what did I tell you? We need to reduce the treatment time. So we look at her, and this is a surgery. Ah, tu vois, regarde. Là, quand il fait ça, il décolle. Non, non, mais des fois, il plante. Okay, so we carefully reflect the flap. Look at that, you see, and we will use the piezo to go, you see, around the teeth carefully to be able to extract easily these teeth and preserve all the ridge. Okay, then we use betadine and peroxide to disinfect this, and you need to clean this alveolus. You don't need to have even if you have an infection, you clean perfectly good, you curate, you do betadine, peroxide, everything will be fine. And then when you have a case like this, you know that you have a strange anatomy. So you take a big burr and you can carefully reshape, you see, the bone in order to have a more even anatomy. This is what you can see there, and you are not going to see different length on the teeth. And it's much better to have longer teeth from 2 millimeters, but on the same length, we will have a more even anatomy than get a long tooth, short tooth, and this. When people place implants, usually, they just think about adding bone, but very rarely they think about removing bone. My first strategy is to remove the bone I need to remove every time. So like this, implant will be placed at the same level. Emergent profile will be optimal. Hygiene, aesthetic, speech, everything will be facilitated by this procedure. So you need to reshape the bone every time. You see, if I had a ridge there, I would reshape to have the shape of the tooth. And then we go to the sinus. And you see, she had no bone in the 2 millimeters in the distal. And the question is, you crazy, you're going to do immediate loading in a case where you do a sinus elevation? I say yes, if I got enough good bone in this region. You see, I got enough good bone, then I found that maybe I could add 2 implants distally, do my sinus elevation, and connect all my ridge in an arch, so I don't need to have 75 here, because I will get at least 4 implants with over 70. So now you can remove your flap and you can elevate your plate of bone with a 701 or 703 Fisher burr, or with a piezo surgery, or combination of that. But you need to be very careful when you reflect this membrane. You can or not let the piece of bone into the ridge or into the sinus, or remove it as you like, doesn't change anything. But once you've done that, okay. Once you have done that, you see, look how carefully I do it. you can use PRF to double the membrane. So like this, you are sure not to have any kind of fissure or opening on the membrane. If you have one, you see it was mobile, so it was perfect. But if you have a fissure, or anytime you use a PRF membrane, and it will close, and definitely this opening or this wound in the membrane. And then we do exactly the same. In an alveolar, it's good to use MP3 because you can compact with the compactors. The compactors I developed are sold in France by Pred. Maybe we could think about with southern implants, they could distribute these instruments, which are, I think, really good because you can compact the bone. And you see, I compact this, I put this implants, they go carefully, slowly, they're not aggressive. I'm not frightened in the difference of other implants to break the ridge, you see? So we have enough initial stability, but it's not too aggressive when you come to the neck of the implant. So this is extremely good. I am at 80 newtons. I use the hostel. I was 72 to 74, and then I can go to the distal implants. So you see, I place this membrane, and I use a sticky bone in this sinus. And you see that then that I can place the distal implants, drill on the other side, like that, place the membrane, compact the biomaterial, compact the sticky bone carefully, and you see how slowly I place those really nice implants. I have 8 implants now. We are not in all on 4. It's not the case for all on 4. She wants immediate loading, no bone. We have to be on the safe side. Look, the implants are parallel. Look at the beauty of the connective tissue here. Matrix suture. We don't try to close completely. We have the PRF membrane beneath the flap. We have the PRF membrane on the sinus. You see, we are sure not to destroy to have all the biomaterial going to the sinus. And now we can connect those implants perfectly well with, of course, a rich framework to go to immediate loading. But now I have to tell you that by compacting the biomaterial labially, this ridge will stay with years. I have cases for over 10 years with no recession. I've been the first in the world to tell that you need to compact the biomaterial. I've done this for 15 years. We had the histology done by Denmark. You know what? I had no time to publish on that. I will do it maybe because I'm a clinician and I have nothing to prove. I was happy to compact, happy to have the wonderful result. My patients were happy. I told this during my lectures, and those who know me know that I do this. But I'm happy to know now that more and more research shows that I was right. Some studies from Romanos, from Chi, from another one, and we're publishing also a study together with Denmark on that, shows that we compact the bone and we have better results, and we have this on histology. So, my friends, you should compact the biomaterial as much as you can if you want to have good results. Then, of course, I am using this biomaterial, this MP3, for my socket preservation. And some people may say, okay, but osteobiol, we don't know really more. We know some Swiss company, and as a company with a lot of research, you don't have enough research for that. I just have to, if for those who tell this, you have to know that there have been over 220 articles related with these biomaterials. You can get them. And just on socket preservation, there are some of the articles written on this socket preservation using this kind of biomaterial from osteobiol. Just to show you what has been done, and you can get them through Southern Implants, osteobiol, or myself, if some of them of you want to have more bibliography according. But we know that we are working with something we have been studied, and our patients are not guinea pigs. And by compacting, you have to trust me, compact the biomaterial, it will change your life, definitely. So the question is, can you immediately load the full arch? Go to immediate loading, prefabricated provisional restoration, when you have from 25 to 76, which is what we got. Answer is yes, because we have a full arch stabilization. If it was one single tooth, we need over 70. But if it was 25 in the posterior, this will be as when you break your leg, you put a metal piece into this to connect the broken pieces of bone. And this is exactly as an external connection for those broken bone. So you can see the case and the X-ray. Look at the parallelism of the implant. Look at we have nothing left, 2 millimeters in the posterior. We could place 11 millimeter implants in the posterior, 13 in the anterior with a good value. And now we take a perfect impression. Temporary restoration is extremely important. Temporary restoration should fit, should be reinforced by wire or acrylic or whatever you want, but should be reinforced. You should carefully check the occlusion. When I do a case like this, I see my patient, check the patient the following day, because when they are under sedation or when they are with anesthetic, they don't feel. So they may bite like this or like that. Following day, you check. Within 3 more days, you check. A week, 2 weeks, a month, you check. Extremely important. You can even put a night guard if you're frightened for parafunction. But occlusion is the key for success. So if you have a premature load on some implants, immediate loading, you may lose implants. So it's not just a surgery. But look at the case the following day. She came, look, we used a PRF. So on this guy, we modified it, placed a little bit more PRF membrane, look a little bit strange. Look immediately at the soft tissue here. It's beautiful, healthy, and the papilla is there. Emergence profile, going straight from the implant, no compression. If you have a compression emerging from the implant, soft tissue will disappear. Bye-bye papilla, bye-bye aesthetic, bye-bye patient. Time goes, we remove the bridge to remove sutures. 10 days later, look at that. Look at that with the compression of the biomaterial. Amazing, no? And we have added the tissue. The level is the same. We see papilla is growing. Will take a few months, you see, but look on the facial aspect. We are not going to lose anything with the time, I swear to you. Look, a month later, tissue is nice. And what did I tell you? First of all, you compact the biomaterial, the ridge will be there. And it's there, okay? And if you have no compression, papilla will grow from 2 millimeters. So if the patient, oh, I have a black hole now, I said, don't worry, this will disappear. So when I go to immediate loading, I tell my patient, you are going to have several things to understand. First of all, when you will go out from my clinic, you will be extremely happy because you'll have beautiful restoration, fixed restoration, and this is magic. Following day, you will be happy as well because you will not have any pain, okay? But then after a week or a few days, you will come back and say, doctor, this bridge is a little thick. Can you trim the bridge because I don't like this is too thick? And I tell the patient, I don't care. This is as a cast, a walking cast, and the patient is not discussing with the surgeon if the walking cast is too thick and if he cannot run. With a walking cast, you don't jog. We are not going to do a jogging. With a temporary restoration, you eat slow, you chew carefully, exactly the same. and you don't complain if the bridge is thick, because if it breaks, you lose implants. I tell the patient, second thing, you tell me after a month, doctor, now I see black holes. There is a recession, what happens? I say, just soft tissue or tissues are remodeling and taking their position. You have no more inflammation, then you got black holes. This is normal, and I don't care. You tell them. If you cannot speak too much, not a problem. When you had the denture, you couldn't speak. But you have to tell this, because I know that this will change if you have an optimal anatomy of the temporary restoration. And you have to tell them, if I reduce the bridge, and if you break the bridge, okay, you reduce the thickness of the bridge, you break the bridge, bang, bye-bye implants. You're going to lose implants. Do you want to try? No, no, no way. They don't want to try. Now they're so happy with the teeth. They all adapt. She's extremely happy now with the treatment. Look at that. She has teeth. She had nothing when she came. She has short teeth. You couldn't see when she was speaking. And when she smiled, you see, you don't see too much the things there, the black holes. But the thing is, that time goes. Look at that. After a few months, 3 months, tissue is getting really nice. Now we are ready to go to a definitive restoration. But look at the beautiful emergence profile. Look at the level of the implants. Look at the level of the soft tissue, you see. And you can play a little bit because we're going to gain even more. But to compare to what she got before, this is magic. My friends, this is absolutely magic. We are going to change the case, and we are going to evaluate, you see, to see how much we can correct the anatomy to get the best aesthetic result. Question: how frequently should we check the occlusion? As often as possible. After delivery, at the time of delivery, immediate checking. Following days, 2-3 days, patient come back and you see if everything is fine. You see sometime they say, oh, I just on one side, it's normal. Yeah, normal, don't worry. Then 1 week, 1 month, 2 months, according to the patient, it varies. Some patient, you get the occlusion immediately. Everything is fine, everything is perfect. Some patient, you need to wait, and they will change every time until it becomes stable. Because you have a major change sometime in the occlusion. You augment the vertical dimension. You have several factors to take into consideration, and you have to adapt to the situation. Question: how long should the patient function with the provisional restoration prior to the final restoration? You know what is the answer? 4 to 6 months, which is a base. But if you need to wait longer, this is not a problem, because the patient has a full fixed restoration. And if you are not very safe, because it was a fall in a sinus elevation, you don't know about the occlusion and things like this, you can wait 8 months, not a problem. But this is fabulous, because patient is extremely comfortable, extremely happy. Most of them are not so happy about getting to definitive restoration. But look at this patient when she came. Look at that. We couldn't see her teeth. You see in her eyes, she was not happy. Look at that. She was a little bit frustrated because she felt bad, because she stayed decades with a denture. She's quite young. She's still a beautiful woman, but she's not happy because look at the wrinkles. She has a witch chin characteristic from the dentulous patient. You see, she has no lip support. So there's the wrinkles and the lines are marked, you see. But within few weeks, she changed to that. Look at that. Same haircut, same patient. She's 10 years younger. But more of that, she is now confident. She's happy. Look at the eyes. Look at that. You see with the eyes if the patient are happy or not. So within one single surgery, we could do extract the teeth, disinfect, remove infection, do sinus elevation, place the implants, play with soft tissue, augment the reach with the biomaterial, do the the provisional restoration and change the occlusion, the aesthetics, the smile line, everything. And this is what I call a simple treatment. And you know that simplicity is the ultimate sophistication. This is not for me, this is Michelangelo. And we agree together about that. Okay, my friend, we're going to get now 10-minute breaks. You need to have a coffee, relax, because I want you to be really careful about what we're going to discuss later on. Okay, 10-minute break. We start at 30.
Okay. Stay tuned, please. We come back.
Voilà. Alors, les arbres
So please, everyone, come back to 11:30 to come back to the course. Thank you.
parler aujourd'hui. Voilà. C'est bon. Je te montrerai, tu vas voir. Ok. Voilà. Il peut, là, non. C'est possible. Il ne peut pas cet après-midi. Je vais amener la Harley à la révision. Voilà. Okay. Perfect. Very good. Hope you could have a little espresso or tea or whatever you want. And we're going to start for 1 hour and a half again. So you have seen how we can manage this kind of cases. But I'm going to show you more cases to see that this can be more complicated. And even if this is complicated, we can still stay with the same philosophy. One of my forces is that I have always done the same thing every day. Since 1985, I placed my first implants. I climbed the steps gently, but when I knew something, the base was there, and then I climb and the base is there, and then I climb and the base is there, and then I use everything. If you want to change every time everything, you will fail because you don't know what is good or wrong. But if you take your philosophy, if you take your experience and redo every time the same thing, every day the same thing, you will get a good experience. So what I show you, for example, I discussed about autonomous bone graft. If you are able to do it, you're happy with them, no problem with that. I don't want to tell you that what I do is what you have to do. What I want to show you is that we can be simple and treat extremely difficult and sophisticated case, as you're going to see more. But if the base is there, you change, you see even with one single tooth, is premolar, we change a difficult case with the same protocol in an easy case. We extract the teeth, we compact, we place the implant, and load. Same thing. And now let's see this patient. She comes, and it's a case that Dr. Laplan, Theo Laplan, has done the prosthetic restoration, or are doing this case now. And she comes, you see, with a denture, a removable denture in the posterior. And you see, by the pressure of the denture and the loss of posterior support, she became a patient with a deep overbite. Because she lost the vertical dimension. Look at this in the posterior. Look, these teeth, look at that. All the front teeth went down. And we even don't see what's happening in the lower jaw. And then she broke part of the lower jaw. She has a removable in the posterior as well. But the removable, with the pressure of the removable, she lost all the vertical. And she wants to be treated. Okay? She's very upset about this situation now. Look at the difference. This is the position we should get. We should augment the vertical dimension from a significant value. But she broke all the teeth there in the lower jaw. And we can see that she has an abscess there. She has some pus. So there is an infection problem there. This tooth has to be extracted. And if she has no premolar and we just keep 1 or 2 teeth in the lower upper jaw, it's better to extract everything and treat her from the start. Okay? If we check what's going on, look on the side, we need to think about the aesthetics, but we are going to augment the vertical. So we need to be sure that she will be available, comfortable with that. Sometimes they are, sometimes they are not. But as she's going to get a lot of pressure in the posterior, we need to have a very solid temporary restoration. When she opens, you can see that she lost the vertical, but she broke the lower jaw, most of the teeth. And the thing is now, on a financial point of view, she can't afford to do everything at the same time. So we told her that, okay, we're going to start with the upper jaw because it's a critical situation in the upper jaw. And she will have a bite plane for the posterior to check, to control the occlusion in the night. So like this, she will be able to function until she will be able financially to treat the lower jaw. You see? We decided to add a new posterior support with a removable in the posterior. And then if we get a good posterior support, she can stay like this with some broken teeth because she stayed for years like that. But now we need to see what will be done on this case. Look, she has this removable denture. Look how much she grinded. Look at that. We have to, we suspect that she is a bruxer, but we don't know if she bruxes because she is not comfortable with actual restoration or if it comes from here. You know, when bruxers come, it comes from here or from there or from both of them. So we have to evaluate what is the situation. But this is extremely important because if we can't control that by night guards or a good occlusion or physiotherapy or whatever, we may face problems. Then we'll need to check what's going on. We first discuss with the patient, we see what's going on, we see she has bone, okay, no real big problems. But if you carefully analyze, she lost bone here and there, and you see, maybe if we treat there, if we see in the posterior that she lost bone here, she just have those 2 teeth there, but you have not too much bone in the lower jaw. She wants to have a definitive treatment. She comes from far away. Every time she comes, she has to take the train. And you see now with all the confined situation, lockdown, is quite difficult to come many times. So maybe one option could be to be very sophisticated. We do a bridge from there to there and augment the ridge posteriorly. And we know this is on cases like this quite difficult. So a lot of surgeries, augment the ridge, place implants, lot of implants. We may place 3 implants there and 2 or 3 there, 6 implants. Why? Maybe I'm a little bit provocative. If we extract that, put it in a good level, place 1 implant there, 1 here, 4 more there, 6 implants, same amount of implant, immediate loading, she comes, done. If we need to remove the bridge, extract, reduce endodontic treatment, reduce the perio, augment the ridge posteriorly, place implants, wait for the ridge to be augmented, wait for the implant to integrate it. How many times she will come here? What will be the cost? Even more, because we need to have an orthodontist bone graft. And if we extract this within a sequence, done, she comes, finish, she leaves. This is an option, my friend. I don't say this is the best, and I respect if you want to keep the teeth, but you have to understand she stayed with those teeth for decades, and then we have to redo all the upper jaw. The same dentist did everything, and maybe we have decades beneath the bridge, and it will be more complicated. So just try, I am provocative to help you to think differently. We should not think today as we did before. In the upper jaw, especially this patient, I tell you, is so happy about the kind of treatment we did for in the upper jaw that now she comes and she says, you know what? I put money aside. Next month, you do the lower. Sold. And in this period, always good to sell cases. But if you see in the upper jaw, you may say, oh, I want to keep the teeth because those central are good. Yeah, no problem. You want to keep. What will you do there? You have a decay, okay? You have a deep pocket. If you want to preserve the biologic width, space between the bone and the base of the crown, you lost bone to here. So you should remove the bone up to there to be able to have the margin. We have to extract this one because she has infection there. Look, there is a pus there. We have a decay there, okay, and problem as well here. So we keep 3 teeth. Other thing is, place 8 implants, bang, bang, bang. Avoid this region where you have infection, place implants there, posterior, immediate loading, and we can check the occlusion, augment the vertical, and get aesthetics. Let's see what happens. You see, when she smiles, it's okay because she opens the mouth. So the space, the face is acceptable. But she's not happy like that. You see? But when she smiles, look at that. It's ugly. She don't want, she says, I hate my smile. So if we grind the bone, as I showed you, keep the level, have a more even anatomy, remove this big piece of bone from block who went down because of the lack of posterior support, we can reshape and do a plastic surgery in the same time. And you know, in 1 day, 1 surgery, she will have a dramatic change. So let's go for the surgery. Same, look, we start with the posterior. We carefully go into the sulcus to try to preserve as much connective tissue as we can. Carefully reflex the tissues. You see, always the same thing. I take a lot of time. I re-entry many times when I do this thing because I like, you see, to have this kind of scallop incision, precise incision. It won't bleed. If you are fast, you save time, but then you lose time because it will bleed. Tissue would have to re-entry, to reshape and everything. Every time when I give my lectures, the participants start to show it's very slow, this guy. Because I open and I go back and I re-entry and I go on one side, on the other side. I want the tissue to be carefully reflected. I go carefully with the piezo to take the time around the teeth. I say, oh, it's so long. But suddenly I'm awake and bang, extract the teeth, very easy, quick, place implants, extremely quick. I'm one of the quickest in the world. in placing implants. You see? And now you drill. Look at them again. You see? We start here. Look how I go into the sulcus carefully against the bone. And I go on the other side and I go carefully and I try to reflex the flap because sometimes you may have an infection, you may have a concavity, you need to see where you are. And you see, carefully I go all around the teeth and extract my teeth so easily now. Look at that. Nothing comes by itself. And then I will do the same thing I do every time. I preserve all the ridge. I go with this into the extraction with the piezo. I try to reflect the flap to see where I am. Very high, you see? And now I place my betadine plus a peroxide. Let it act for a few seconds and dream. And then I take my big burr like this. And now I'm going to make my hole. You can use a surgical guide if you want. You can use a guided surgery. You can do a navigation system, whatever you want. I got an award, the first Nobel Pharma Award in 1995 for the biggest development in osseointegration. And I came, the little guy from south of France, with two ideas. First of all, optimal implant positioning and papillary regeneration technique. And I'm extremely happy and proud on one way to realize that 25 years later, my ideas are still there. And why do we use guided surgery, navigation system, sophisticated guide? Because we want to be precise. And then together with the connection between the brain and the hand, you use whatever you want. But I've been developing also all the ARC system, the Nobel guide. I've used them, but now my connection is such that I know what will happen, what will emerge from the implant. And with my little tools, the positioning guides, I can do whatever I want. So I start on the palatal side because you can be palatal parallel in the good angulation. You want to use coaxial implant, you can, because it's another way of treating. But if you can go parallel, it's another way too. So no problem with both clinical situation. But if you want to use normal implant, you drill on the palatal side, as I do, okay, like this, and you will drill from this situation. And you can see, look, I am on the palatal side. When the normal ridge is there, you know that the space between those implants will be 7 millimeters from center to center. When you place your implants, you should have from center to center from 7 to 8 millimeters, because you will get 2 to 3 millimeters between implants. And if you get 2 to 3 millimeters between the base of the implants, you will get enough blood supply to get papillas. That's so easy. If the implants are too close, you will never get a papilla. If the implants are too wide, the space between implants are too big, you will not get a papilla. My friends, listen to that. If you have a patient with a diastema, does he have a papilla? No, no papilla. So how do you want to have a papilla if Mother Nature is not able to build a papilla? You are not stronger than Mother Nature. You try to match, you try to adapt, and you have to think of what's happening in life. So if you have a good space between implants, then it should be okay. So it's good to use all the computers you want, all the surgical guided you want. The optimal thing is space between implants and angulation. Space between implants, angulation, done. And if you have a normal ridge in a normal arch, as we have here with normal teeth, we will always get from premolar to premolar 7 to 8 millimeters. If you lose some of the teeth, the ridge will be reduced. And then the space between implants, between teeth, won't be the good one. So you need to promote the space between implants. In this case, in this particular case, we have all the teeth are there, the ridge is normal, so you know that if you drill into the alveolus, the space will be good. This is what we do now, and we continue. Now we have drilled, we use this burr. We use this burr. Comment s'appelle ces fraises? Non, non, les fraises Conical. Voilà. You know, we drill now. We have the direction indicator in place. We place the guide. 7 millimeter. The guide is surgery. The fixture positioning guides. And we go to the next step. And you need to follow the sequence. And sometimes in the anterior, I use this tapered drill because when you are drilling into dense bone, if you are not using this drill, your implant will be tilted labially. So you need to be this to place your implant into the optimal position like that. Look how it goes very easily because I've used this tapered drill. They are fabulous. And especially in the lower jaw where the bone is dense, I always use them to be sure that everything is fine. And then what happens? I check the tail. I am 75. I am green, you see, orange 68. Here, 68, here, 72 over 75. So between 68 and 75 from the anterior. So I know now that my case is done. I'm in success rate. I use a flag long for use for molars, premolar, molar. I'm parallel, I drill, and then I go to the distal. But you know, I have defined at the time of surgery when was a success. Now, even if the bone is a type 4, I don't care because I have the initial stability in the front. And I have the same thing in the posterior. You see, look how it goes very carefully. This implant is really a wonderful implant. It's very soft, you see, and you're not frightened to break the bone, but you get in the top, you get, look at that. This premolar here, 80. The other one, 80. We can hang the patient to the ceiling. Everything will be fine. Then we place a multi-unit abutment. We place, and then we use, look at that. We use GTO. Because on this region, now I want to use this biomaterial now because in a big alveolar, I can shape the biomaterial, fill the space, and this will become very hard. And I'm going to use as well this GTO on the facial aspect to augment the soft tissue support. Look carefully at what I'm going to do now, how I am using this GTO for a fully case or anterior case. When I have my extraction, I match, and then I will compact carefully, and then I will add the GTO all on the facial aspect. If you have a concavity, GTO will stay, and you will reshape totally that. I put an excess of GTO, and I'm going to suture here. Just to show you how I drill and how I place. If I use this drill like this, the implant will stay into the good position perfectly well. Everything will be fine. Look at that. I will be able, sometime you can compact the biomaterial before or after. If you use GTO, I would rather do it after implant placement because if you put the GTO, it will stick to the instruments. So, place the implant, check, orange, green, we are in a good way. Now, look at that. I can carefully, I show you this again, reshape, compact, reshape, and compact. And it will become hard within few hours. So the biomaterial is exactly as the MP3 that Laplan told you, but now this additive will disappear and the biomaterial will become hard. And you see, look at that. You see the tissue looks nice, but you will see the healing. The healing using GTO is absolutely incredible. This is one of the keys. But I place my 8 implants. When I go immediate loading, patient like this with parafunction augments the vertical dimension. I prefer to have the safety belt, 8 implants. If they don't want, I don't care, because if you put 4 or even 6, you lose 1 implant, you need to replace, restart the case. You place 8, you are not frightened, you are better anchorage into the bone. And if you lose 1 implant, you can still do the final restoration. But look, after 1 week, look at the tissue after 1 week. Stitches are still there, but look at the beautiful tissue there. Look at that. After 1 week, we have the illusion we are 2, 3, 4 weeks later. And we have added the GTO. And suddenly, the anatomy is really even, harmonious. And look at the shape, the texture, the color of the soft tissue. Look at the central papilla. Look at the lateral papillas. You have a little bit of scar there, and you will see with the time, the scar will be a little bit there, but it will disappear with time. Occlusal view, look at the ridge. Look at that. We have recreated a nice shape. Remember, there was depression there. There was a depression here. Look at the alveolar we closed. When you extract a tooth, by placing MP3 and compacting it, or by using GTO and compacting, will allow you to keep the width and the height of the ridge. It means that it will stay where it's now, and we are not frightened by having recession with time. I've done this MP3 for 16, 17 years, the GTO for 4 years. We have been the 3 first in the world, together with Ulf Danmark and Roberto Rossi, to use this biomaterial, and we all agree in this. Tissue will stay. Look, parallelism of the implants, everything is stable, implants are perfectly placed. We take the impressions, and the bridge is placed, perfectly adapted, you see, with the optimal emergence profile to avoid any complication, any compaction of the papillas into the this region. And papilla will stay, you will see. But you see, once again, we have changed an easy case in another, in a one-day case. We could have kept some teeth. We would say, well, I would have trained, you need perio surgery, you needed apical prepositioning flap, you need endodontic treatment again, you need to do the temporary restoration, you need to place the implants, another partial denture, wait for the implant to integrate, then come with the final restoration with a complicated treatment. Will be more expensive. And the thing is, this patient would not have done that. So especially now, they hate to come to the office. This patient, she come to see, hello. And when she come for trying for the prosthetic restoration, it's not a surgery. So it's easier to organize first. And she's not as frightened as she's there. Look at the emergence profile. First of all, you can see that by using my surgical instrument, my fixture positioning guides, I had a good space between implants. When there is a molar or a pontic, there is a pontic, and implants are optimally placed. You can see that on the base of the titanium, we have a perfect optimal emergence profile with no compression at this level. If you see from the occlusion, you can see the titanium base, and you see no compression like this. And when we remove the bridge, it's a normal view. It's a little bit of plaque there because we remove and we show you how it's a real life. And even with a little bit of plaque, a little bit of plaque there, soft tissue is fine because of the optimal emergence profile. Okay, so precision in implant positioning. Look at that. All those implants are placed perfectly well. I almost never use angulated abutments because I place my implants like this. But if you feel more comfortable to use coaxis, absolutely no problem. Every time there is several ways to go to the good result. But look at that. I'm fine. Implants are, the restoration is good, and patient is extremely happy. But now this is one week, 10 days. We remove stitches and look first of all at the level. Okay, level is even. We are lacking a papilla here. There is still a little bit of inflammation there, but look what's going on here. And you tell the patient tissue will mature. But look at the anatomy. You remember how she was? She has long teeth now, longer, more aesthetic, and she will get the same in the lower jaw. Okay, tissue is healing, and if she is able to maintain, to control this, tissue will reorganize perfectly well in this level. But patient is really happy now because we check the occlusion, we have changed the posterior, look at that, removable denture, we have changed the teeth. We kept the same denture with just acrylic has been replaced. So now we check the occlusion and the patient is really satisfied. We can check the occlusion, see if she's available, she's comfortable or not. And you can see that we can check on all dimensions and she is very happy. And tissue are really nice. Look at that. Look at that. After a week to 10 days. Now when she smiles, she's like this. You see a little bit of, she complains because she can see a little bit of black triangle. And she say, oh, look, my teeth are longer on this side. No, it's not your teeth are longer. Your smile is on the side. So take pictures when they come because they forget that. And if you have a picture or a movie when they smile and they speak, you can say, look, I didn't change. You were like this. So it's why this is so important to take pictures and movies when the patient smiles, speak, and have a normal life. But time goes. Look at that. Suddenly, what happens? Papilla go down. Tissue mature. A month later, look at the shape, the color. Everything is very nice. She's extremely happy about the treatment, and everything looks really nice for her now. Okay? The occlusal view. And more maturation. There is still a little bit of, you see, maybe there was a little bit of too much of tension when I sutured, but this will carefully, slowly come back to normal because everything came back to normal all around here. Look at the papillas, look at the papilla here, and look at the tissue. Remember, we had a concavity, okay? And we filled at this level everything with GTO. And we added the GTO on the facial aspect. And on this side, there was a big recession. You see concavity on this side. Everything is flat now. The view from the front, we came there to here. You see the change? No compression. Mother Nature is on our side. And patient is extremely happy with that. But now, look at that. Look at that. With a beautiful restoration done by Dr. Laplan, we have no compression and soft tissue loves that. Look at that. Perfect, no compression and the papilla is here. And you see, as I told you, we extracted the teeth, we have the shape. We did nothing, no connective tissue graft, nothing. We played with the hard tissue to augment the soft tissue. But look at the tissue now, suddenly looks very nice. Mother Nature would just look at this newly formed papilla. It's going up. And look at the tissue inside. Look at that. Everything beautiful. And then, today, the fashion is to use custom-made abutments. You will, and it's nice. There's a lot of good practitioners who work with that, and it's interesting. But you know what? I am very basic, very simple. Don't you think it's nice? With basic cylindrical abutment, stupid abutment, we can get this result. So if you can get this result with simple treatment, of course you can fashion it, reshape the abutment, whatever you want. It will be nice, but not better than this. So we are wondering, do we need all that? And all my cases are done on screw retain restoration, multi-unit abutment, and I have 30 years of background with this kind of abutments. And the tissue will stay. And if you need to remove, it's much better than cemented restoration, because if you have a fixed arch, you have to adaptation, you have to any kind of adaptation, you break a tooth, you lose an implant, whatever, you can remove, unscrew, reshape, modify, screw again. So this is something reliable, totally into this phenomenon of COVID or whatever. Okay? Look on the closer view. Look now, the anatomy. Remove. Remember, she got here so much recession. You remember the shape? Remember? We have recreated a nice shape all over. And in the anterior, no more concavity, no more depression. Look at that on the cuspid area. We compacted the GTO. Look at that. Tissue is so nice here. Everything is perfect. Now we are able to go with the final restoration, and everything will be fine, and the patient will be happy with a newly formed restoration. But now, there are some cases where some people who promote autogenous bone graft will say, okay, gold standard is a autogenous bone graft. So all this is this stupid thing with biomaterial is no worries, not. I have to tell you, this GTO is surprising, amazing, is changing my surgical life. As conical implants with good grip changed my life in going to immediate loading. But I have done so many autogenous bone grafts through the years that you cannot tell me that I'm switching or I'm going to this biomaterial because I am frightened about taking bone. I've done more than everyone else. And this is a case 18 years ago, this young patient knocked to my door. Young patient, beautiful girl. She had a boyfriend, and the boyfriend gave her a kick in the face. Not very elegant. And she's not unhappy because teeth became black. Soft tissue started to retract, and teeth started to move, to be mobile. And she comes to knock to my door and say, look, I have a problem. I say, what did you do? You have a problem? Yeah, I have a problem with my boyfriend, blah, blah. First question you ask her before you start the treatment. What should be the first question? First question is, do you change the boyfriend? Because if she gets the same boyfriend, you don't want to work for 1 year and do bone graft or whatever. When she changes the boyfriend, same boyfriend, another kick, and you start again. So first question and first thing, this is real life. You have pieces of metal, but you have a living patient above that. On top of each implant is a patient. You should think about that. But if you were fashionable today, you will tell me, oh, case like this, no problem, without taking care and analyzing the case. I extract, immediate loading, temporization, final restoration, done, one shot. Okay, this is what we would do if we want to be simple. But you need not to forget what you know. Then you take an X-ray and you look at that and you see you have a knife edge and she lost all the bone. And in a case like this, if you lose all the bone, at this time, we have no way to treat her other than taking bone from somewhere else. In a case like this, we decided to take bone from the chin. Why? Because the convexity of the chin will match the convexity of the lost ridge. And if we prepare the ridge in a perfect way, as marquetry, you see, prepare the recipient site, measure carefully, go to the chin, take the piece of bone, screw the bone with a very tight connection between the graft and the recipient site. The way for the blood cells to go from the recipient site to the graft will be very narrow. Blood supply will be there and the graft will be living. And if you can perfectly tighten and screw your graft into position, the graft will stay. This I've done so many times. I used to do 6 to 8 bone grafts a week, every day. And I was very fast. And I love doing that. But most of the patients didn't like. One day I got a patient who told me, you did a treatment 15 years ago, and I was so happy now I come back to see you. Ah, I'm glad. But I have one question. Yeah? Was a big guy, strong guy. Do you still take pieces of bone from my skull or my chin or whatever? I said, no, now I say, okay. Because it was the only thing I didn't like to have. Now you do whatever you want. It means that if you can simplify the treatment, reduce morbidity, patient will accept the treatment. But in this case, particular case, I went down to the lower part of the roots of the incisors. After preparing my recipient site, I took measurement of the bone graft. I started to prepare my graft, put my 3 holes, which will be the holes for the screws, okay? Remove the part and will place the graft. Look how perfectly adapted is the graft. Look how much we have gained in this situation. And some people say, oh, with my graft, I lose 20% of, I have 20% of resorption. I didn't have, because the fit was optimal, was a key for success. And the 3 screws allows me to be very stable in my graft. And then I added some biomaterial to fill the space around it. You see? But if you look on the right-hand side, what do you see? Was 1904, no, 2004. You have a PRF. 16 years ago, I was already using PRF to protect my graft, because Joseph Choucroune was my anesthesiologist, and I've been doing PRF for 20 years now. Everyone's speaking about PRF. I have 20 years of experience as well with PRF. And it was a very good thing to reduce complications because of the better soft tissue healing. It used to boost soft tissue healing. That's why I love PRF, because it's on our side, it's a plus to help maturation of the soft tissue. And I was very happy to show such a X-ray, because look, we could recreate a nice ridge. The bone was there, and the bone was so nice that we could go to immediate loading, use the Nobel guide. You see, it was 15, 16 years ago. So I have been using all that, and go to the prefabricated temporary restoration and I was the first. I know this because I fight it at the time in the presentation with the company. I was the first to present the Nobel guide with a flap. Because at this time, the company used to say, you have to follow the protocol, and this is a flapless surgery because of aesthetics. And they try to fool us to tell that if you do a flapless surgery, you would go to aesthetics. My friends, I tell you, you have your background. You know what you do. Preserve your background. Is not because you have a new implant, a new technique, a new component that you have to forget everything. Remember, you have to climb the steps gently, like this. I knew how to create the papilla, a central papilla. I lost tissue. I wanted to use my technique. That's why I reflect a flap to be able to create a papilla. Have a nice girl, nice patient, very happy, and everything went well. So for those who tell me that this is a gold standard, I say yes. But the thing is that for those who tell me that is the only way to treat patients, I say no. Because I've done much more before, and you will see even more now. And another time, I will explain you how to augment the reach perfectly well and to treat this case with GTO, what I'm doing now. But this is for another time. I'm not giving you everything today. Then after, you don't want to see me anymore. But just to let you know that in a case like this, the use of GTO will help me. Because if you look at this case, you say, oh, you could go to immediate loading because you have the height. So even if the nerve is here or there, maybe you can place 4 or 5 implants and go to immediate loading. Except the fact that you need to carefully analyze the case. If you see what's happening there, and if you see the recession we are having there in the front, you think that there is something wrong happening. And if you go to the X-ray, you see that there is nothing left. So no way to place an implant here with nothing to be done. And this could be a good case for autogenous bone graft, but the graft could be from cuspid to premolar to premolar. Big graft, we need to remove. Where do you take the bone? In the lower jaw? If you place the implants, there is no bone here. So you can go to the lower jaw. You go to ramus, maybe. Okay, but you take big pieces of ramus, both sides. Very aggressive surgery. Or you can go to the hip if you want, or the skull, whatever you want. But to stay 2 donor sites, 2 surgical sites, and wait with no teeth for a long time. Okay? So in this case, I had a different option. I placed my implants and added GTO, but I didn't go into immediate loading. I'm not crazy, because if I wanted to do another way, we could have cut the bone here and place short implants. But if we can augment the ridge and have longer implants, on aesthetic point of view, hygiene, cleaning, much better. This is what I decided to do. So and you see that if you are not using you see the bone is so thin that I needed to use, again, the piezo surgery to remove that, to extract the tooth with preserving the little piece of bone we got. Then we re-entry. We have placed those 6 implants. We close everything. And when we re-entry, a little bit here, we have placed those 6 deep conical there. And we have added the bone. And we are placing, look at that. The nerve is here. Here. This is due to the concavity we can see. We couldn't place 1 implant there, but 6 implants is more than enough. And place the 6 abutments. We could keep the soft tissue, you see. If we have reduced the bone up to this level, we would have very long abutment, difficult cleaning. Soft tissue is always very thin and difficult to maintain, so more risk for recession. By adding the biomaterial, we could place 6 good long implants 11 millimeter implants, perfect, parallel, no angulated abutment, no all on four. Even in a difficult case, I still use my parallel implant because it's easy. It's so easy to place those implants, okay? But I want you to check something. Look at that. Look at the bone you have recreated by adding the GTO on the facial aspect. Do you think I would have done better with autogenous bone graft? Look at that. Everything is really nice, healthy. Everything is good there. Look at the level. Look at the bleeding. Look at the ridge. Remember the X-ray? It was a knife edge. All this has been created by starting from nowhere. Flat. Knife edge, there. All this is an extra. Look at the beauty of the tissue. Now, after we waited for months, it was time for us to create the bone. And now we are going from aesthetic fixed restoration. So we have not gone to immediate loading, but we waited for months and we have created the ridge. Nice ridge, nice integrated implant, and nice restoration. We are going to reshape the soft tissue, wait for months because it's a difficult case. We are not in a hurry to go to the definitive restoration. Now this patient, she comes from Saint-Tropez, near 200 kilometers from Marseille. Her dentist did the definitive restoration. Everything is fine. She's extremely happy and everything is fine. But can you imagine how much we have simplified the treatment? Of course, that was not a case for immediate loading. So you don't have to be crazy. In anterior ridge, when you lose so much bone, in cases like this, don't be crazy. Be on the safe side. But this will change your life because you will see so many cases you can treat with immediate loading in changing your treatment philosophy. Do we do immediate loading everywhere? No, not everywhere. In a case like this, we always have to keep simple. This patient comes, a young patient, 20 years old, multiple anodontia. Look at that. It's terrible. He grind the teeth up to there. Here, look at that. And now he has this space, no teeth in the lower jaw, knife edge, exactly as this case is why I showed you the first case to say that I'm confident now that by using the GTO, I will recreate a knife ridge there, okay? And I'm going to treat this patient, but it's a combination about what did Dr. Laplan on his case, augmenting the vertical dimension, okay? And what we did just before, augmenting the ridge with the GTO and placing those deep conical implants. So we're going to do the surgery. But look at that. On the lateral side, look at that. He ate his cuspid. Look at that, of the shape. Amazing. I've not so many times seen something like this, but I know now that I don't need to add a dense graft here. So the treatment will be to treat him and to place in one shot as many implants as we can. Look when he opens, look at that. I've not so many times seen things like that. It goes both sides, okay? And the ridge is flat here. So we are going to analyze the case, do the wax up, look at the x-ray, do whatever, and no time for that, just to show you that we have done the same philosophy, but we are here. If this guy has such an occlusion, is so ugly smile, it's not a problem for him to get a removable for a few months. So we are not totally into the fact that we need to go to immediate loading in a case like this. So look when he bites, look at that. When he bites like this, we are going to carefully reflect our flap, preserve this quantity of connective tissue, and understand that you have to preserve that because the position of the implant, you understand, won't be this one. So we decided we needed to really analyze this before placing the implant. Think first and then cut. So we take the time to remove tissue and keep as much tissue as we can here. Same thing, we reflect the flap, there will be a concavity apically, you see, and we will add GTO on this side. And we are going to use the piezo surgery again, remove, look at that, same thing. All cases are the same in Marseille, suddenly. And we're going to extract those centrals, although because it's not into the fact we say, oh, we could keep these teeth, go to orthodontic treatment to do what? Anyway, we need our implants. And this guy now is, I didn't take a picture of the face, I didn't show you, but this guy is bad in his life, you see? So he's not really absolutely ready to go to a big major orthodontic treatment. So in this guy, we extract in one shot, we clean, place implants, and close and wait. Okay, same thing, but look at the alveolus. I don't know where we're going to place the implant, but then we need to reshape carefully as we did before, like this. Look at that. Now, as he has the short teeth, we can be a little higher. And we start with the cuspid, both sides, where we have bone. Okay. And this can become a premolar if you want, because we'll see, because the space is huge. Look at that. We check the occlusion. This is the base. We check the occlusion, you see? Everything is perfect. So this is good. The vertical is fine. We go to the palatal side again. First hole is on the palatal side, and we'll use a conical drill. And then we go to the lateral here. You see? 7 millimeter, we are just in the middle of the two teeth, but it was flat, so we don't care. We are going to fill this with biomaterial. But now we have the two teeth like this. Now we use a flag again, 7 millimeter here, and we're parallel, the two teeth parallel here. Okay, and now suddenly you see that if we do that, we will have two centrals in the optimal position. With my stupid instruments, I was able to understand what we do. And now in this case, we don't know if you have 3 premolars each side or not. It's not a problem, or if it's okay, but cuspid, lateral, 2 centrals, and you will have a beautiful smile. Then again, you see, we go and we push, you see, on the palatal side, and we'll do the same thing, add the biomaterial on the facial aspect. He's a young guy, he's 19 years old, or 20 years old. We need to be on the safe side, so we use this GTO and compact the biomaterial. And I know with my background that within 15 years, everything will be there. Implants are placed into bone. Look at that. You see, we have the stop, I want to stop here. Look at that. You see the concavity here? Now, what can we do? Or let it like this and have some kind of recession there, or put a big, thick part of GTO to augment the ridge, and the ridge will stay there. So I place my implants into my optimal position according to my final desired restorative restoration, prosthetic restoration. And I add the biomaterial there, and I will have a more even anatomy, more bone, and with the time, it will be on the safe side. We will be on the safe side. Look at that. On the other side, we're on the palatal. Look at that. We push with the finger. Look my finger here. I push. I'm very strong, because if not, implant will be tilted laterally. Okay? And then I push. I will close this. I place my cover screws and look at the positioning of those implants. Perfect. on this side, one there, two here, and we added GTO on this side. But we are parallel, everything is fine, and we are going to get a really nice result. We are on the phase of reconstructing the restoration. Next time I see you, you will see this case finished. But it would have been a mistake in this case to go to immediate loading. We needed to be sure and safe, you see. But you see that suddenly, in a case which seemed to be very complicated, in one surgery, two because there will be the second stage surgery, in two surgery, we were able to, one major surgery, one 20-minute surgery, we were able to recreate a nice base for a future fixed restoration. We will be able to augment the vertical dimension, the smile will be nice, and this case will be an absolute success, I'm sure. So I told you to be simple, okay? What if we have a more difficult case? I have a message from my dear friend Roberto Rossi. Hello, Roberto, nice to see you. And this is a big guy from Genova. I think everyone knows Roberto. It has been a pleasure to work with him developing all this technique. And this is a guy from Lamina. So now we're going to see what's happening with more severe cases. When you see this patient, you understand she will become a severe case. Nice woman, elegant woman. She is in a big stress because she has a denture. She's a beautiful woman, and she came and she's extremely aggressive because she was not lucky. She got an implant here. She got implant the posterior. She lost all implants. She got this stupid removable denture here. The smile is a disaster. And she come and say, you see, very difficult patient to handle, really. So before starting with the treatment, I have to discuss with her. I say, what do you want? She said, I want a fixed restoration. I said, difficult. I don't want to suffer. And I don't want to stay without any teeth because my husband still don't understand or doesn't know that I have a removable. So I have to stay with teeth every time. This is the key because it's a difficult case. But you do whatever you want. But I tell you, I've been traumatized by the treatment. I'm not an easy patient. And I knew she was not an easy patient. And you carefully look at that, you say, now there is something wrong. What is wrong? If you look to the removable, there is an implant here. Tissue is blue. The recession is big, huge. She has a lot of acrylic there. And I start to understand that she lost a lot of tissue. So if she lost tissue up to there, what will be into the patient's mouth? It will be crazy, you see? And she's aggressive. She don't want to have pain. She don't want to suffer. Only thing she wants, she was okay, is to pay. So this is a good thing, at least. But look at the side, terrible. The drama, it was pus here, all infected. The implant is here, I don't know why. For what, you see? And look at the difference between these two and this one, and this one. I want to have a nice shape. She shows the gums, and with this, she lost. So I started to understand it would be a difficult case. Look at that, a higher magnification. Look here and there. On the distal, we are there. On the other side, the same. And if we remove the implant, it will be up to the nose. And if we go here, it will be to the nose. And she wants aesthetics. Okay. On the palatal side, she had no, she was brave because she didn't want to show she has the removable. So she stayed with this stupid denture with no clips because she didn't want to show she had a removable denture. In the lower jaw, nothing special, except she has no posterior support. But so far, the big problem now is in the upper jaw. Then when you have a problem, you need to identify what are the problems, okay? Lower jaw is bone. There will never be a problem. It will be a piece of cake. But now, we see she's not happy. Nice woman, okay? But she see we don't sleep too much. She's in the eye, she's depressed. But she can change, we can change her. But she don't eat, so she lost weight. She don't speak and smile and don't laugh at all because she's afraid to lose the denture. So she's miserable. She's so aggressive. You know what? I was thinking, shall I treat this patient or not? She was so aggressive that and then I started to fight a little bit. Look, if you continue like this, I don't treat you. So or you keep quiet, you listen to me, you accept what I tell you. If not, far away. And I know I am your last chance. I know that. So now be quiet, respect me. If not, I don't treat you. Patients need to understand that is a present we do for them. I don't care about, because some patients, they think they're going to pay you, that you can kind of say whatever they want and do whatever they want to do. With Theo Laplan, today we discussed with a patient, one patient, she's son of a bitch, woman of a bitch, and then we discussed today, she had an appointment yet tomorrow, we cancel. Bang, bang, ciao. Ciao is for Roberto. We adapt. Eh? Look at that. Now is the case. Now is the case. So can we be simple in a case like this? If you want to go with autogenous bone graft, good luck. And she don't want to stay without any teeth, of course. She don't want the patient husband to understand she's going to get surgeries. And you see, you have a little smile, which more nervous smile than a real smile, because this seems to be a really tough case, okay? But now there is this implant, we know we're going to lose bone up to there. And if you look at the x-rays, look what's happening in the posterior on one side, this shell, okay? Look what's happening on the other side. And the little piece of bone we had, we are going to lose because we're going to lose him to remove this implant. So we start to understand that it's difficult, but in the front, it's not bad. So we decide, before extracting those teeth, because the denture wants, she's acceptable like this. So we say we will do a relining of the denture, okay, remove this implant, and let it stay like that. Because if she has a denture, there will be pressure on the whole palate, and she will have to stay without any teeth. And we need to be very careful, because if our pressure with a denture, with no bone, implant could go into the sinus, and we may lose implants. So, but I accepted to treat her, you see. But look at there where we had the implant on the base. Look at that. It's nothing. Again, piezo surgery is interesting to extract those teeth. But if you look on the 3D reconstruction, look at that. A little bit of a difficult treatment. Knife edge. Not only there is no bone, but it's a knife edge. Look at that. Nothing left. So if you don't rely on your biomaterial, if you don't rely on your implant system, please don't treat that. Okay? I've been using this osteobial material for 16, 17 years now. I know what they will offer to me. I've been using this 1000 implant for years as well. I know that this implant is really very soft, and I will be able to get enough catching of the bone to help me. So now I know that I will treat this case. This is how she is now, okay? And I will try, if possible, to simplify the treatment, okay? So look at that. Look how much she lost. Nothing left. I know definitely I'm not going to go down, okay? This will be pink acrylic, but it will be, I have to explain her that from there to here, she will need to spend minutes, tens of minutes and hours maybe to clean If she doesn't play the game, I don't treat her from the beginning, because if she's so difficult to clean and she's not able to clean, she will lose implants. And then we have to start again, and then it will be too late. So, but she was a very clever and nice patient. Once we became friends, everything was fine. She was a lovely person. And now she's the best person in the world. But look at that. Look at the color, the shape, the texture of those tissues, incredible. We need to remove that. So this is the surgery. Look at the mobility. In France, we have Mistral, you see. If you have too much Mistral, this is the wind we have in France, the teeth will leave, will fell out. So we have to reflect the flap carefully. Look at the knife edge. It's an eggshell with a knife edge. Then we go carefully with the blade, you see, with the blade and the burr, and then we go with the piezo. Oops. No, it's a problem now. We start again. Okay. Look at the mobility of the teeth. We carefully try with the blade to figure where is the bone, because we don't know where is the bone. There is nothing left, you see? So carefully, and we are going to keep those two centrals at least. So now we see the bone. You see where we are now with the, I've been doing this with a Fisher burr for years. You can just use, if you are safe, the piezo surgery, because it's longer, but it's safer to not to destroy the membrane. But look at that. I carefully, this is an eggshell, nothing, 1 millimeter, okay? I keep the piece of bone, because if I remove the piece of bone, I'm afraid to tear the membrane. And then I start to drill, because I know that they're not aggressive. I may be able to place some implants there. I use the flags and milestone, same thing. You see, I'm so simple. People say this instrument is too simple for me, and they don't use. But it's the best instrument in the world, I tell you. I wouldn't do any surgery without it. And then I take an angulation on this side, because she lost so much that I try to adapt. But even with this angulation, she will have no angulated abutment. You see, because she lost so much. But then in the posterior, I cannot play too much. Then I went to, Dr. Shukroun was here. He prepared me some PRF, sticky bone. It was so Genos plus PRF. And we started carefully, you see, slowly to try to place the implant. Very careful. Look at that. 1 millimeter, and the implant is there. I do place the other one. Look how soft, how very smooth this implant, very gentle implant. You see? According, look. There is a fissure here. You see? And then I place the GTO. And in fact, I place the GTO in the sinus and realize the GTO in sinus is not the best. Because I know that in the sinus, we find some resorption. And I would have, today, I would use just sticky bone, which is better than GTO. We got 25% of resorption when you use this. And I plan that placing just 2 implants and GTO, I would get a big piece of biomaterial, which I didn't get. Placing GTO plus implants in sinus was fine. But then when you do just place GTO, for some reason, the resorption is more important than when you use sticky bone. So for sinus today, I am on the safe side with 4 years of experience, sticky bone plus Genos, finito. Everything is fine. But this is what I did. So I placed 2 implants, and I hope I would be able to place more implants here. But I was happy to say, because if I place 2 implants here, they integrate. More implants they would integrate. I could extract the teeth in the second stage and go for immediate holding. You see, because you don't want to stay with the denture. So now we go to the other side. Reflect the flap. You see, it's better to go one side, go to one side, you see, finish, you go to the other side when it's too complicated. Then I use, there is a hole, you see? No problem, because I will use a PRF membrane. And look at that, the bone is so thin. I try to drill carefully. I use the denture burrs to try to augment a little bit the initial stability. You see that because there was nothing, it was a paper. And then I put the PRF, you see, And on this side, I used the sticky bone. And look, I carefully place my 2 implants here and there with a long shaft. You see, I push with my finger to feel. Look, I use a denture burr again to augment the initial stability. And I try to put GTO again on this side because I still was, I don't want to change everything, you see, in 1 minute. So I knew GTO was seemed to be okay, but I knew that sticky bone was good. So why changing everything? But as I wanted to use GTO to augment, you see, the labial ridge, because I knew that sticky bone will resorb, but GTO won't on the side. But on the sinus, GTO will resorb and sticky bone won't resorb. So in my mind, that was the connection, because I wanted to add a little bit of support here because it was too much palatally placed, you see. Then this is what I did on this case. And I kept this because she had the denture, even on this implant even if it was a stupid implant, it helped me to keep the denture in place. Then there is we did some temporary restoration, and this is a new temporary restoration, removable restoration, to check that the occlusion was fine and to see what would be the future, okay? And patient was very happy because of, he said, if it's like this and fixed, it will be really nice. And she was so happy. This we have seen. You see, look at the tissue we lost. But now we have an idea of the future restoration, and we have an idea that if the implant integrate into this both sides, we will be able to extract the anterior, place the implants, and go for final restoration. Okay? Look how high. And I tell her, look, you will have to be able to clean that. Okay. Look at the difference. We have extracted the implant, okay? We have cleaned and placed 1 more implant here. Now, you see how she smiles? And we can go to the final restoration, temporary restoration. And look where we are now. I got those implants, 1, 2, 3, 4, 5, 6. Not bad. I decided I would now add 2 implants, but now I can go to immediate loading. So we extracted this, we placed those more implants. Here is the implant I placed in the zone, and here is a bone where I could get. And I decided to add 2 more implants because the ridge was quite thin, and she was a really tough patient. I would have loved to place 2 more implants and to come back on this and reshape, but she wouldn't allow me. 1 surgery for the first sinus, 2nd surgery, extraction, implant placement, immediate loading was enough for her. So I added some implants, you could see. I add 1 here, but this one didn't integrate. I added here, I didn't integrate. And this is the side where I placed more GTO. This, I showed this one. Okay, I put on my hand. Okay, but you know what? Everything is nice. Look at the prosthetic restoration. It's very stable, very nice. Patient is extremely happy. You know what? Since that day, she's not the same. She laughs, she smiles. And when we place a restoration, you see, this is the final restoration. When we place the restoration, we have the compression of the tissue. And you know, it's just to answer the people who try to spend a lot of time at the time of implant placement, reshaping the soft tissue. Okay, but if tissue is living, you compress, it's white, okay? It's frightening, Look at that. It's all white. So you're crazy. You compress tissue. No. Within 20 minutes, it'll come back to normal and tissue will adapt. And then when you remove the bridge, you have the shape and it's done. And with doing nothing, you have done things that people take a lot of time. I don't say it's bad to reshape if you want to do it, but it will take time, energy, and I don't know what is really the benefit. But again, I respect all techniques. These are beautiful techniques developed by excellent practitioners who know what they do, and I love them. So just to tell, there are several ways. And in a case like this, it's, I don't have time to play with this papilla, which is very high. You see, she don't want. I have my multi-unit abutment, takes definitive restoration. Look how happy she's in one shot. It's white, it became pink, and look at that. Look at that. I change, doing nothing. And you say, oh, how can she clean? She can. We have tried with the proxy brush, with everything, she can. But you see, look at the smile she could get now. We have changed totally this patient, totally. Now she's ready to do the lower jaw. But look, time goes. Look at the papilla. Remember the color, the shape, the texture of this tissue were pink, were bluish. Now everything is so nice. Beautiful restoration. We have changed this patient and she's now on the way to treat the lower jaw in one shot because now look at the ridge here. You see? Look at that. Few implants, immediate loading, okay. But you know what? So far she's okay. For me, job is done. Okay? If she's happy like this, I will be happy as well. But look, with a higher magnification, within few months later, you see, she's able to maintain, it's clean, no plaque, nothing. Because this patient, she came from so far that now she is able to maintain because she don't want to lose the implant, she don't want to go back to where she was before. Look at your smile of this beautiful patient now. Different patient. Time goes, a few months later, everything is perfect. On the side, and look at the patient now. Look at the change. She gained 10 years. And you can see she's so happy. Look at the, you see, I told you, look at the light in the eyes. May speaks for you. Very happy patient. You see, this is why I showed you that once you have good implants, good biomaterial, good technology, and you have a good connection between the brain and the hand, you can do wonderful things for them. And this is a pleasure. You see, even when this COVID came, I was wondering, shall I continue to work? I have the time to be retired. Okay, I still in good shape. I proved everything. I've given courses in all over the world. I got enough money to live normally, you see. But the thing is, smiles like this push you to continue, you see. And this is what's a good thing. PI used to say we want to help the patient who lost the smiling parts of their bodies. And this will stay in my mind forever because he knew everything. Pierre Brennemark developed, invented, knew everything before everyone. Every technique coming has been developed by him. Short implants, narrow implants, grafting, everything, immediate loading. You see, and some people say, oh, I want to do two-stage surgery because I am straight, follow the PI protocol. PI was not like this. He had amputees. They put a piece of metal in the leg and the patient wanted him to walk right away. So we follow what the master said, wanted to do, because who else could do better? Patient who lost a part of the leg in a mine, you see, and then he put the implant in the leg and immediate loading, the patient walks immediately. And you tell me you don't want to go to immediate loading? So my friends, I hope you had a good time as I did with you. except I imagine my friends there on the other side. I hope you enjoyed, and I hope that definitely we will be able to see each other later on. I have to thank Emmanuel Escalon from Southern Implant. I have to thank Sue Graham, my dear friends from Southern Implants, for the relation we have together. And this is the most important thing we have together. You see, friendship, relation, and honesty to do the best for the patient and not being crazy. Money comes, patient come, you see, and the more you refuse patients, the more they come. The strict you are, they know that you are there, they respect you, and then when you start to respect, no problem. For all your life, it will be fine. So, thank you very much. And Sue, you want to speak? Who wants to speak? I don't know. Or it's finished or what?
Yeah.
Okay.
Sue, do you want to make a conclusion?
Yes, Sue has to make a conclusion.
Yeah.
Yes, we want. Yes. There's no one in the room, so we.
Yeah, I thought it was a fantastic lecture. Thank you very much for your time. It was very detailed, a lot of beautiful cases, as always. I think everybody certainly learned a lot from this. Can't wait to use it in training. And yeah, like I said this morning, I'm looking forward to future similar events. You just have magical hands. If I ever need an implant, I know where I would like to go.
Thank you. Thank you, Sue. Thank you, everyone. And good luck. And once this bullshit will be out, we'll see again and enjoy life again. Yep. But we try to adapt, and this is what we do now. And stay safe and treat your patient in a safe way, and we'll have long, nice years in the future. Thank you.
Thank you, Patrick. Thank you, Emmanuel.
Okay.
Bye. Thank you very much. And we can catch the replay at the end of the week, or maybe next week. And if you have any question, don't hesitate to send us a question on Southern Implant France or Southern Implant
Ciao, Roberto.
Bye-bye. Have a good day.
Ciao, all of you. Okay.
Thank you.
See you.
Bye-bye.
Bye-bye. Bye.